Welcome to this lecture of the Normal Puerperium. Postnatal Clinical Review, Management, Advices, Contraception. By the end of this course, the student will be able to define puerperium, appreciate the physiological changes happening during the puerperium, give advice regarding breastfeeding and breast care, care of the perineum, diet, immunization, exercise, medications, and others. Counsel the couple regarding the appropriate method of contraception. Identify different psychological problems that can happen in this period. Identify the tasks that should take place during the postpartum visit. The puerperium is the period from the completion of the third stage of labor to the return of the pre-pregnant physiological state. It lasts 4 to 6 weeks. Multiple anatomic and physiologic changes occur during this time, and the potential exists for significant complications, such as infection or hemorrhage. Involution of the uterus. The uterus regains its usual non-pregnant size within 5 to 6 weeks, shrinking from 1000 g immediately postpartum to 100 g. This rapid atrophy occurs because of the marked decrease in the size of the muscle cells rather than the decrease in their total number. Involution of the uterus is due to catabolism of the uterine muscle bulk, with the fundal height decreasing from the level of the umbilicus on day 1 postpartum to not being palpable abdominally on days 10 to 14. It returns to a non-pregnant size within 4 weeks. Breastfeeding accelerates involution of the uterus because stimulation of the nipples releases oxytocin from the neurohypophysis. The resulting contractions of the myometrium facilitate the involution of the uterus. The cervix involutes with the uterus and the os is closed by 2-3 weeks. Within several hours of delivery, the cervix has reformed, and by 1 week, it usually admits only one finger, i.e., it is approximately 1 centimeter in diameter. The endometrium starts to regenerate 2-3 days postpartum. Vulvar and vaginal tissues return to normal over the first several days, although the vaginal mucosa reflects a hypoestrogenic state if the woman breastfeeds, because ovarian function is suppressed during breastfeeding. The muscles of the pelvic floor gradually regain their tone. The uterus contracts throughout the period of involution, which produces afterpains, especially in multiparous women and nursing mothers. In primiparous women, the uterus tends to remain contracted tonically, whereas in multiparous women, the uterus contracts vigorously at intervals. Lochia is the uterine discharge following delivery. Lasts for 3 or 4 weeks. Foul-smelling lochia suggests infection. It passes through 3 stages. 1. Lochia rubra. This blood-stained fluid lasts for the first few days. It may continue till 14 days. 2. Lochia serosa. This discharge appears 3 to 4 days after delivery. It is paler than Lochia rubra because it is admixed with serum. And this may continue till 20 days. 3. Lochia alba. After the 10th day, because of an admixture with leukocytes, the lochia assumes a white or yellow-white color. This ceases by 4 to 8 weeks. Return of the elastic fibers of the skin and the stretched rectus. Muscles to normal configuration occurs slowly and is aided by exercise. The silvery striae gravidarum seen on the skin usually lighten in time. Diastasis recti, separation of the rectus muscles and fascia, also usually resolves over time. You should encourage exercise. 1. The changes that occurred during pregnancy, e.g., increases in heart rate, cardiac output, and blood volume, generally return to baseline by approximately 6 weeks postpartum. 2. Peripheral vascular resistance also returns to the pre-pregnancy level by this time. 3. Most of these parameters return to normal within the first 2 weeks postpartum. 1. A marked leukocytosis occurs during and after labor. The leukocytosis, primarily a demargination event of granulocytosis, may be as high as 30,000/mm3. 2. Pregnancy-induced changes in blood coagulation factors persist for variable periods of time after delivery. Elevated plasma fibrinogen levels are maintained at least through the first week of the puerperium. Glomerular filtration rate represents renal function and remains elevated in the first few weeks postpartum, then returns to normal. Therefore, drugs with renal excretion should be given in increased doses during this time. Ureter and renal pelvis dilation regress by 6 to 8 weeks. There may be considerable edema around the urethra after vaginal delivery, resulting in transitory urinary retention. About 7% of women experience urinary stress incontinence, which usually regresses by 3 months. Non-lactating women. The first menstrual flow usually returns within 6 to 8 weeks after delivery, with ovulation occurring at 2 to 4 weeks postpartum. Lactating women. Ovulation is much less frequent in women who breastfeed compared with those who do not. The first menstrual flow may occur as early as the 2nd month or as late as the 18th month after delivery or even after cessation of breastfeeding. 1. Amenorrhea during lactation is due to a lack of appropriate ovarian stimulation by pituitary gonadotropins. 2. Nevertheless, pregnancy can occur with lactation. Nursing mothers must understand that ovulation and pregnancy can occur even in breastfeeding amenorrheic women. Ovulation is often inhibited in breastfeeding before 10 weeks, if lactation is suppressed, it may occur at 7, 10 weeks. In general, in lactating women, prolactin remains elevated for 6 weeks, whereas in non-lactating women, prolactin levels return to normal by 3 weeks postpartum. Non-lactating mothers may begin using a contraceptive soon after delivery if they wish to avoid becoming pregnant. Oral contraceptives. Depomedroxyprogesterone acetate. Subdermal etinogestrel implant may be offered before discharge. Lactating mothers may begin using progestin-only oral contraceptives as soon as their milk supply is established. Progesterone-only contraceptives such as oral contraceptive pills, depomedroxyprogesterone acetate, etinogestrel subdermal implant, do not appear to have adverse effects on lactation. Combined oral contraceptives, containing estrogen and prolactins, should not be used because the estrogen in these pills suppresses lactation. It is called ethinylestradiol. Patients for whom the use of oral contraceptives is contraindicated or who prefer other methods of contraception, such as foam or condoms, should also be offered instructions in their use. Other methods include 1. Intrauterine devices, IUDs, do not interfere with breast milk. However, IUDs are generally not inserted until 4 to 6 weeks postpartum. 2. Diaphragms or cervical caps cannot be fitted adequately during the immediate postpartum period, and their use should be delayed until after the 4 to 6 week examination. 3. Spermicides and barrier methods have no effect on breastfeeding. Lubricated condoms may offset vaginal dryness secondary to breastfeeding. 4. Fertility awareness methods, such as the rhythm method, are difficult to practice accurately before the resumption of menses and therefore are not recommended. Lactation. While there are rare contraindications such as infections that may lead to an increase in vertical transmission to the infant, or in the case of mothers on medications or using recreational drugs that could be dangerous to a newborn, the vast majority of new mothers should be encouraged to breastfeed. Women who breastfeed are more likely to lose the weight they have gained during pregnancy. Further, women who have breastfed appear to have a lower long-term risk of developing type 2 diabetes and its associated morbidities. Progesterone, estrogen, placental lactogen, prolactin, cortisol, and insulin act together in stimulating the growth and development of the breast's milk-secreting apparatus. 1. Prolactin, which is released from the anterior pituitary gland, stimulates milk production. Initiation of lactation. The delivery of the placenta causes a sharp decrease in the levels of estrogens and progesterone, which, in turn, leads to the release of prolactin and the consequent stimulation of milk production. B. Continued prolactin production. A stimulus from the breast, e.g., a suckling infant, curtails the release of prolactin inhibiting factor from the hypothalamus, thus inducing a transiently increased secretion of prolactin. 2. Oxytocin is responsible for the letdown reflex and the subsequent release of breast milk. Stimulation of the nipples during nursing causes oxytocin to be released from the posterior pituitary gland. A number of barriers to breastfeeding, both iatrogenic and natural, can be introduced in the birthing process and initial postpartum period. In a variety of complicated births such as a preterm birth, emergency birth, or simply a cesarean delivery, the initial skin-to-skin contact that has been shown to initiate breastfeeding in the neonate is interrupted. The misalignment of expectations and reality coupled with concerns about providing adequate nutrition of the neonate leads many women to give up breastfeeding for formula feeding only a few days postpartum. 1. Breast milk is ideal for the newborn because it provides a balanced diet. 2. It contains protective maternal antibodies, and the maternal lymphocytes in breast milk may be important to the infant's immunologic processes. 3. Most drugs given to the mother are secreted in low concentrations in the breast milk. 4. Water-soluble drugs are excreted in high concentrations into colostrum, whereas lipid-soluble drugs are excreted in high concentrations into breast milk. All postpartum patients need breast care, regardless of whether or not they are breastfeeding. Patients usually experience the onset of lactation, engorgement, or letdown, approximately 24 to 72 hours postpartum. When this occurs, the breasts usually become uniformly warmer, firmer, and tender. Patients often complain of pain or warmth in the breasts and may experience fever. For patients not breastfeeding, ice packs, a tight bra, analgesics, and anti-inflammatory medications are all useful. Previously it was thought that those who were exposed to pertussis or were vaccinated as children received lifelong immunity. However, recent findings suggest that immunity may only last up to 20 years. Consequently, many women in their childbearing years run the risk of contracting pertussis in the postpartum period and transmitting the disease to their infants prior to their scheduled immunizations at 2 months of age. With a general rise in the incidence of pertussis, routine postpartum immunization of women with Tdap is essential if they have not received the vaccine within the 10 years previous to pregnancy. Caregivers who will be in close contact to the infant should also be vaccinated to create an immunologic cocoon. Mothers found to have low rubella antibody titers in their prenatal laboratory test results should receive a measles, mumps, and rubella, MMR, vaccine postpartum as well. The vaccine is a mixture of 3 attenuated live viruses that cannot be given during pregnancy. If a woman is found to be Rh negative at the time of her prenatal laboratory tests or a type N screen, it is necessary that she receive an intramuscular injection of Regam within 72 hours postpartum. Shortly after delivery, the parents become totally engrossed in the events surrounding the newborn infant. The mother should have close contact with her infant. Obstetric units should be organized to facilitate these interactions by minimizing unnecessary medical interventions while increasing participation by the father and other family members. Nursing staff can observe the interactions between the infant and the new parents and intervene when necessary. Postpartum patients should be encouraged to begin ambulation as soon as possible after delivery. They should be offered assistance initially, especially for patients who have delivered by cesarean section. Early ambulation helps avoid urinary retention and prevents puerperal venous thromboses and pulmonary emboli. It is common for a patient not to have a bowel movement for the first 1 to 2 days after delivery, because patients have often not eaten for a long period. Stool softeners may be prescribed, especially if the patient has had a 4th-degree episiotomy repair or a laceration involving the rectal mucosa. Periurethral edema after vaginal delivery may cause transitory urinary retention. Patient's urinary output should be monitored for the first 24 hours after delivery. If catheterization is required more than twice in the first 24 hours, placement of an indwelling catheter for 1 to 2 days is advisable. Coitus may be resumed when the patient is comfortable. However, the risks of hemorrhage and infection are minimal at approximately 2 weeks postpartum. Women should be counseled, especially if breastfeeding, that coitus may initially be uncomfortable because of a lack of lubrication due to low estrogen levels, and that the use of exogenous, water-soluble lubrication is helpful. The lactating patient may also be counseled to apply topical estrogen or a lubricant to the vaginal mucosa to minimize the dyspareunia caused by coital trauma to the hypoestrogenic tissue. Maternal postpartum weight loss can occur at a rate of 1 kg per month without affecting lactation. On average, a woman will retain 1 kg more than her pre-pregnancy weight at 1 year postpartum. There is no relationship between body mass index or total weight gain and weight retention. Aging, rather than parity, is the major determinant of increases in a woman's weight over time. Residual postpartum retention of weight gained during pregnancy that results in obesity is a concern. Special attention to lifestyle, including exercise and eating habits, will help these women return to a normal body mass index. Follow-up care that has been arranged for the newborn and frequency of health care for the new mother should be reviewed. Postpartum follow-up of any pre-existing medical conditions should also be reviewed and, when needed, the patient should be referred for care. Postpartum blues. Mild, self-limiting low mood in the postnatal period. 80% of new mothers. Postnatal depression. Pervasive low mood in the postnatal period. 10% of new mothers. Puerperal psychosis. Acute onset of psychotic illness in the postnatal period. 1 per 1,000 new mothers. Etiology. Poorly understood. Thought to be related to falling levels of estrogens, progesterone, and cortisol postnatally. Association/risk factors. 1 past psychiatric history. 2 previous postnatal depression. 3 antenatal or delivery complications. 4 primogravidity, postnatal blues. 5 social isolation. Postpartum blues. Emotional lability, irritability, poor sleep, and concentration. Often day 3, 5 postnatally. Postnatal depression. Low mood, decreased appetite, early morning waking, anhedonia, anxiety. Often occurs up to 6 weeks postnatally. Puerperal psychosis. Mania, delusions, hallucinations, thoughts of self-harm. Often presents day 3, 7 postnatally. Examination. Mental state examination, depression scales may be used. Management. Postpartum blues. Reassurance, support, self-limiting. Postnatal depression. Depends on severity, counseling, CBT, antidepressants. Puerperal psychosis. Psychiatric emergency requiring inpatient admission, antidepressants, antipsychotics, ECT. 1 complications for emotional attachment to child. 2 long-term psychiatric morbidity. 3 suicide, up to 5% with puerperal psychosis. 4 infanticide, up to 4% with puerperal psychosis. Prognosis. Recurrence in subsequent pregnancies. 1 postnatal depression 30%. 2 puerperal psychosis 20%. After a vaginal delivery, the above issues of perineal care, contraception, and breast care are discussed with the patient. Further, a discussion regarding how common the postpartum blues can be as well as the availability of professionals to talk the patient through any problems as she transitions to home can be of help. Patients who have a cesarean delivery should be counseled regarding wound care and activity in addition to the above. With fan and steel incisions that were stapled closed, the staples can be removed prior to discharge. Patients are often advised to avoid heavy lifting, nothing heavier than your baby, and vigorous activities including driving. Before patients drive, it is recommended that they try to slam on the brakes as an experiment to be sure they are comfortable enough to drive. While still in the hospital, the patient often needs instruction about care of the neonate, breastfeeding, and her limitations during the ensuing weeks. The patient needs emotional support during the period of adjustment to the new member of the family and to her own physiologic changes. Given that the risk of postpartum complications can extend past the average patient's hospital stay, partners and family should be included in any maternal or child care counseling as available. Routine medical issues in patients after vaginal delivery include pain control and perineal care. Usually, pain can be reduced with nonsteroidal anti-inflammatory drugs, NSAIDs, or acetaminophen. Low-dose opioids are occasionally required for adequate patient comfort, particularly at the hour of sleep. For patients with vaginal deliveries that involved either episiotomies or lacerations, perineal care is particularly important. Ice packs around the clock for the first 24 hours can be beneficial for both pain and edema in the perineum and labia. When inspecting the perineum of a postpartum patient, it is important to ensure that the perineal repair is intact and that no hematomas have developed. It is also important to note whether the patient has hemorrhoids, which are common in pregnancy and postpartum, particularly after a long second stage of labor. These should resolve with time, but patients' symptoms may be ameliorated with over-the-counter hemorrhoidal medications, stool softeners, and ice packs. As more than 30% of deliveries are now by cesarean, wound care and pain management in these women are a common component of postpartum care. Local wound care and observation for signs of wound infection or separation are part of routine care. NSAIDs could be used for the cramping pain caused by uterine involution. Patients have usually received a first or second generation cephalosporin during the cesarean section as prophylaxis against infection. Although it is routine in many institutions to give additional dosages, this has never been shown to further decrease the risk of infection.